Welcome, everybody. I know we'll still have a few people come in the next few minutes, but we're going to go ahead and get started to make sure that we have time for me to take all your questions at the end. So before jumping into my presentation, first I'll just say I'm Jason Schwartz, Director of Outreach, National Council State Boards of Nursing, but I want to acknowledge the Illinois Nursing Workforce Center, which gave me the invitation to be here with y'all. So I'm just going to read this to make sure I don't miss anything, so pardon me for that. This presentation is occurring with support from the Illinois Nursing Workforce Center, which is a resource for current and future nursing students, nursing educators, and those nurses already practicing in the field. The website, nursing.illinois.gov, has information on affordable education opportunities, grants for nursing schools, and reports from data collected post-license renewal. The Workforce Center, or INWC, works with state agencies, nurses associations, nursing education programs, employers, and state and national foundations to focus efforts on the Illinois nursing workforce. A couple other quick notes. This program will not include CEs, but the program will be taped and within the next 2 weeks posted to the IDF PR YouTube page. I'll also mention for anyone who caught the PN Educator version last week, that is already up on the YouTube page. If you weren't there, but you'd like to see the PN version, you know where to go then. So with that, I'm going to go ahead and share my screen and we're going to jump right in. Okay, so I call this Next Generation NCLEX. We have liftoff, and this is my presentation for RN educators. If you were part of the PN presentation, a lot of it's actually exactly the same, but the examples that I'll use today focus on RN level content, whereas last week we focused on PN level content. So we always start with the legalese, but I like to call it, if you see something, share something. What does it mean? It means those of you that are here today, hopefully you'll learn some good things that would also be of value to your colleagues, possibly your students, and even some of your grads. You're welcome to share it all. There's an email address at the bottom in red. Our one exception is that if there's anything that you would want to sell, you have to check in with us and get permission first. So that's what that's all about. With that, here's what I'm covering today. It's a bit ambitious for our 90 minutes, so I tend to go a little bit fast. Good news, it's recorded and you've got copies of the slides. So anyways, why did the exam change? What do the new items look like? What does the overall test look like? How is it structured and put together now? How does scoring work? Because the scoring's also changed a bit. What are we seeing in terms of early results? And what are some resources and updates that I'd like you to know about from NCSBN? I mentioned we'll try to finish with some Q&A, and anything you can't get me in the chat at the end of this meeting, I'm also going to leave you my email address, because sometimes I know it happens to me, right? You go back to work and then the question pops into your head that you wish you could have asked. And so anyways, I'm here for you whenever you think of that question. So we're going to start with, why did the NCLEX change? And I'm going to take you back 11 years for this. So this is ancient history almost, but here we go. 2012, right? Pre-pandemic. Anything pre-pandemic is ancient history for me. Anyways, the origins of Next Generation NCLEX came at a meeting we had here in downtown Chicago. It was a meeting of a group that we call our NCLEX Examination Committee. Now, those aren't people like me, right, that have been in testing for 25-ish years and have ideas. These are actually regulators from around the United States that would come to Chicago, and they had oversight over the exam. A really important question that was asked came from Dr. Janice Hooper from the Texas Board of Nursing. She challenged us with a question that essentially was, is the NCLEX measuring all the right things? So I'm going to do a little tiny infomercial for a resource that I think you all should know about, and that is our practice analysis, which we publish every 3 years. So Dr. Hooper already knew that we did a practice analysis, which is a scientific study of exactly what first-year nurses do every day. And that ultimately is the basis for the NCLEX test plan and the exam itself. So in a way, is the NCLEX measuring the right things? Well, of course, that's what the practice analysis is for. But Dr. Hooper knew that, so obviously there was something more subtle going on. And to set you up for that, I'm going to give an analogy from high school English. All right, where am I going with this? Well, in truth, any test, whether it's a test that you create or a test that we created at NCSBN, is a combination of two things. It's the things that you want to or should measure, combined with the things you can measure. So sometimes there are things we'd like to measure, but we can't. So high school English, you might have had an English teacher that definitely wanted you to be able to write essays and poems and things like that. But if that teacher only had the multiple choice bubble sheet final exam, you weren't going to be able to write an essay or a poem on the final, right? So we're always limited in testing by what we can measure. So essentially what Dr. Hooper was challenging us with was, with all the advances in technology and even the science of testing itself, are we ready to take a fresh look at clinical judgment? So rather than say, oh no, not us, right? We embraced the opportunity and we kicked off two pretty quick studies following the challenge from Dr. Hooper. So the first was a literature review. What did we find out? And you're welcome to nod your heads. I can't see you. You're all off camera, which is okay. But you can nod your heads anyways. I'll imagine it. Well, we found out that educators already knew that clinical judgment was really important. And many of them were already finding opportunities to teach it because they knew how important it would be for their students when they graduated and entered the workforce to be able to exercise clinical judgment. So educators already knew. Okay, not a problem. We're still going to do the research and make sure. But we also had data from practice. Half of new nurses, and when I say new nurse or novice nurse, think first year of practice. So half of new nurses were making errors. And 2/3 of those errors weren't about not remembering what something meant or confusing this thing with this thing. Now, the errors that we're talking about here, 65% of them related to judgment and decision making. And then you'll see a 20, but I'm feeling it today. I'm going to read it as an 80. 80% of employers were dissatisfied with the clinical judgment or decision-making skills of their new hires. So data from the workforce, again, that really is forcing us to grapple with the importance of clinical judgment. Now, kind of a summary statement from our literature review. This was really the take home. Clinical judgment critical to patient safety and public protection. But I snuck a little phrase in there, even at the entry level. And even at the entry level is really important for two things. Number one, if you think about the NCLEX, the NCLEX is essentially one of the very final hurdles to entering the profession. And what we focus on, like with our practice analysis, is the knowledge, skills, and abilities that new nurses need in their first year, right, at the entry level. So you're preparing your students for lifelong success, which we appreciate, but our test is focused only on that first year. So clinical judgment, if it were critical, year 3, 4, and 5, but not year 1, wouldn't really have a home on the NCLEX. But because it's critical, even at the entry level, even in that first year, if we can figure out a fair and valid way to test it, we actually have an obligation, because the whole purpose of the NCLEX, in fact, the mission of NCSBN, is patient safety and public protection. So that's one of the reasons entry level in this phrase really matters. It means it does belong on the NCLEX. Now, I also like to highlight it because those of you that follow the literature on clinical judgment, and certainly in our office we do too, know that it can and should improve over time with experience. Not a problem. That is all still true. But the point is, it needs to begin somewhere, not at zero. Some baseline level is needed, even year 1. So that's great if it goes up and it gets better later. But the point is, you can't start at 0. So the literature review definitely made a pretty compelling case for clinical judgment on the exam, as long as we could find a fair and valid way to test it. I mentioned a second study. We call it the strategic practice analysis. And there's essentially a thick document you can download, but there's a picture that goes with it that I think people like better. So we're going to pretend what you're looking at right now is a clock. And from 12 o'clock to 7, we've got 63 nursing skills, things like therapeutic communication, for example, things you teach your students that you know they're going to need, right? For the test, well, maybe, but in real life, even more important. Okay. And from 7 o'clock to 12 o'clock, you see 41 nursing tasks, actual things that nurses were observed doing in this study. And so the way the study worked is the researchers essentially followed around the nurses, and as the nurses finished doing certain things and had a spare minute, the researchers would interview them on the various skills that fed in to the tasks that were performed. So researchers love to connect the dots. That's what's going on here. And in a typical example, a very typical skill, it tended to go with 5 to 10 tasks. Really nice validation, by the way, that the individual skills that you're teaching have value in general for a lot of different things. So 5 to 10 is a pretty common picture. As I go around the clock, sometimes we get more, right? Sometimes we get less. That's okay too. But really, at a glance, I think we can tell this one's a lot different from all the others. Skill 33 in the study was clinical judgment. You can see in the picture that it goes with just about everything. And again, you can probably nod your heads because I bet you already suspected that or knew it. But the point is, the strategic practice analysis confirmed for us that clinical judgment wasn't just something that the nurse needed on, we'll call it an unlucky day of the week, but really something that was pervasive throughout almost everything that nurses do. So that was our research basis. And I'll say I gave you about 5 years of research in 5 minutes. Now, where did that put us? Well, clinical judgment, important and necessary even at the entry level. That's really one of the most important things from all of our research. So if I've said it 3 times, that's okay. What else? We did some self-assessment on the exam, right? What did the NCLEX look like in 2012, 2013, 2014? It had some clinical judgment. You've maybe seen sample items or remember from your own exam, there might have been a question that said, which client should the nurse see first? So that's some prioritization, decision-making, judgment involved. But here's the thing. You might have got one of those on your NCLEX. Somebody else might have taken the exam and not gotten a single one. In other words, it was incidental rather than intentional because clinical judgment itself wasn't a category that our computer adaptive testing engine controlled for. So you might get some, you might not. And then also when you think of clinical judgment, prioritization is one slice, but what if we really wanted to check it more comprehensively, right? So anyways, the point is we had a little, but there was certainly room for more. So what were we going to need to do? Well, a lot more work for sure. That's additional research. And we also suspected that we would need some new item types on the exam. We already had multiple choice, select all that apply, some fill in the blank calculations, and a couple other ones we didn't use quite as much. But the point is, it felt like for clinical judgment, which was pretty tough to get at, we didn't want to be the English teacher with the bubble sheets trying to get an essay, right? We really wanted to come up with item formats that were in some sense perfect for these new skills that we were really trying to focus on. So I've given you quite a bit there. I'm going to show you our first big breakthrough. It's probably a thing you've seen before, but before I unveil it, I'm just going to share with you, whenever you see this little thumbnail of a newsletter in the upper corner, it just means want more information about the topic I'm covering? We've got a whole newsletter about it. So let's jump in. This is our clinical judgment measurement model. It's something we developed specifically here at NCSBN over several years. The version you're looking at is our final version, which was finalized in 2019. So if you really were following the progression of next generation NCLEX early, because I think we did put some word out to the public as early as 2017, you might have seen one that was a tiny, tiny bit different, not too much, but the point is 2019 finalized. Why was this such a breakthrough? Well, when we think of clinical judgment, that is a hard thing to test, right? In testing, we have a notion of what we call soft skills, S-O-F-T, if I don't say it well, soft skills. These are things like communication, problem solving, judgment, ethics, much harder to test, maybe even impossible to test, compared to sort of our sweet spot in testing, which is testing knowledge, testing applications of concepts, things like that, right? So clinical judgment, how could we test that? Well, essentially what we figured out was a divide and conquer approach. So I'm going to highlight for you what we call layer 3. And this is, in my opinion, the most important layer out of this whole, this whole big thing. We got a lot of boxes and bubbles and arrows and some pentagons on the bottom. There's a lot going on. But if you focus in the middle at this layer 3, my opinion is it really gives you everything you need. We figured out a nice divide and conquer for clinical judgment was we could divide it into 6 different skills that all added up to the whole thing. And now in trying to measure clinical judgment, what we really needed to do then was just figure out how to test each of these 6 skills. I'm not going to pretend that was a super easy problem, but it at least organized this much harder problem. And my main focus today is to make sure that you really understand what these 6 skills mean and how they translate into the new questions on next generation NCLEX. Because here's another reason this layer 3 is so valuable. Every clinical judgment question on the next generation NCLEX targets one of these 6 skills. So if you understand these 6 skills, you understand everything new on the exam. Not an exaggeration. I'm going to show you exactly how that goes. So what do the new items look like? I'm going to start with the headliner, we'll say, the case study. So the case study is the single biggest, most visible change on the exam, right? When a grad gets a case study, okay, this is no longer, as they say, your father's NCLEX, right? This is something new, case study. So first, I'll just give the anatomy of the case study before we dig in too much. I'm going to highlight where I put the bright number 1. That is the signal to your grads that they're in a case study. That's important to know. Why do they want to know they're in a case study? I'd say at least 2 reasons. Number 1, all that stuff they're going to read is going to apply not just to 1 question, but to 6, right? So read it carefully. And number 2, if they don't realize they're in a case study, they might feel like they're losing their mind because they're just going to go to question after question after question and think, haven't I seen this client before? Is my test broken? So anyways, that's handy. Now where I put the 2, 3, 4, 5, and 6, we call that our real world case. We call that our real world scenario, pardon me. And often we organize the information that we present into these tabs for convenience. Important for you to know, 4 is not a magic number of tabs. This case study begins with 4 tabs. Another case study could begin with 2 or 5. Another thing that can happen with the number of tabs is they can increase as we go. For example, a 5th tab could show up partway through this case study. Now, where I put the bright number 7, well, that's where we keep the items. The right-hand side of the screen is going to be the 6 items that go with this case study, presented one at a time, 1 screen at a time. Now, if you remember from not very long ago at all, there were 6 boxes at layer 3 in the clinical judgment measurement model. And whoops, and I've just mentioned that we're going to have 6 items or questions going with our real world nursing scenario. Not a coincidence at all. In fact, the 6 items are going to target those 6 boxes every single time in the exact same order that they're presented. I'm going to show you how that goes. So first, let's take a look at the scenario. And what I like to do, because I know especially on Zoom, I've got people that might be driving in their cars and their phone is just kind of tucked away off to the side. I don't want anybody trying to read the small print while driving. So bear with me. The nurse is caring for a 17-year-old male client who reports a recent injury to the left thoracic cage. Let's look at the history and physical. Client reports injuring left ribs after being struck by a mechanically pitched baseball in a batting cage last week. Has significant bruising, feels lightheaded. Also reports some intermittent pain in the left shoulder. Denies shortness of breath, but has some discomfort in the left lower chest when taking deep breath. Reports feeling abdominal fullness and is occasionally nauseous. Patient has no significant past medical history. Search history includes arthroscopic repair to the left shoulder for a torn rotator cuff last year. Has not felt well enough to attend baseball practice since the injury. So hopefully nobody crashed, right? While I read that. But anyways, I also like to read it for another reason. And that is when I generally present, I'll say to experienced nurses and educators, you tend to just at a glance take it in pretty quick, right? Probably, 3 seconds, you got it, and you kind of know what's going on and what needs to be done. And if not yet, when you get these other 3 tabs, you sure will. But I do like to highlight for your grads, right, or for your current students, they probably need to spend a little more time kind of going through it, right? And so when I read it aloud, I think it gives more of a sense that this is quite a bit of information here, right? It took me a while to read it. Let's go to the nurse's notes. Patient appears pale, slightly diaphoretic, large amount of bruising noted along the left torso and over the LUQ of the abdomen. Patient's guarded, tenderness upon palpation, dullness to percussion over the abdomen, slightly diminished breath sounds on the left, productive cough noted, ECG shows normal sinus rhythm. Okay, we'll bring it home now. Vital signs, blood pressure 90/50, pulse 116, respirations 24, temperature 97.8, oxygen 98% room air. We'll go to lab results. I may have a surprise for you. Hemoglobin 90 grams per liter, or 9 grams per deciliter, take your pick. Hematocrit 27%, white blood cells 19,000 per cubic mil. Now, here's where I said I might have a surprise. Beginning this past April 1st, so effective April 1st, right? It's happening now. Whenever the exam presents a numerical lab value, it will also present the normal or reference range, which you can see here in this final column. Now, I'm showing it to you in a case study, but it's true for the entire test. Anywhere on the NCLEX, if there's a numerical lab value, there will be the reference or normal range. And that is something new. Before April, maybe when you took your NCLEX, you came in having memorized a pretty long list of normal ranges, and that no longer is required for the exam, right? Might still be useful in real life, so I'm not telling anybody to stop doing that, but the point is on the exam, if we present numerical lab values, we present reference ranges. With that, well, that was a lot of information to get to the first question, but that's kind of how the case study works. So, okay, let's take a look at the first question. Which of the following assessment findings require immediate follow-up? Select all that apply. So what I'm going to do now, I'm going to be your decoder ring, I like to say, for the clinical judgment measurement model. That's where my focus is going to be. Here's how every case study goes. You're looking at one example, but here's how every case study goes. Your grad, right, the new nurse, encounters a lot of information, right? Like those 4 tabs I just read, encounters a lot of information. That's true in real life, certainly too. For you, a lot of information is just fine. You like information, right? For a new nurse, a lot of information can be overwhelming and even paralyzing. So the first question in every case study has a focus of what matters most right now, right? Here were 80 things we just learned about the client and their situation. We can't really react to all 80 things at the same time. What matters most right now? Now we'll ask it with different words, and we'll use a variety of item types. I'll focus on this item type. Select all that apply. Well, this looks just like it, but it has extra choices. We call it extended multiple response, but it's really just select all that apply on steroids, we could say. Point being, we found this to be a very useful item type for clinical judgment. So you'll see this quite a bit on next generation NCLEX. Okay, but back to the clinical judgment measurement model. The first question in every case study addresses our first box at layer 3, which is named recognize cues. But I also like you to go away knowing that between the lines, what we're really saying is what matters most right now. So educators always tell me, Jason, that's great that you want grads to know what matters most right now, but we also want them to know why. And good news for you, we do that with the second question. So let's take a look at the second question in the set. Which of the following potential issues is the client at risk for developing? Select all that apply. So again, we've got a select all that apply style question on next generation NCLEX. 6 to 10 response options or choices is what's presented. That last one had 8, this one has 6, could have been up to 10. Great. Okay, but what are we really asking here? If we read between the lines, we're really just saying, hey, those things that mattered so much right now, why are they so important? Well, in this case, they're so important because the client might be at risk for developing some pretty scary stuff. Okay, so second question in every case study is really, why do those things matter so much? Third question, well, let me show my artwork. So we call it analyze cues in our model. That's the second box, analyze cues. But when you see analyze cues, you can think, why? Why do these things matter? Okay, with that, let's go to the third question. The nurse is initiating the client's plan of care. Complete the following sentence using the list of options. I call this a pull-down menu item because it operates with these pull-down menus and you make your selection. It's also known a little more technically as something called drop-down close, and close is with a Z. So at any rate, we can go either way. But what's going on when we get to the third question in a case study? Well, we have the third box of our clinical judgment measurement model that we're focused on, and that box is called prioritize hypotheses. Now, I'm going to throw you a curveball here. So if you think, oh, I get it, this is easy, well, watch out. Third question in a case study can go 2 different directions, right? I like to say it has 2 flavors, but that's not an official testing term. Okay, one of the flavors is exactly what we're looking at right here. We can see some prioritization. And if I had to describe, right, if I had to describe conceptually what we're doing here, I'd say we are prioritizing some aspect of the client status. Now, that's a lot to fit in one of my little boxes, okay? But we're prioritizing some aspect of the client status. That's a pretty common thing to see when you get to the third question in a case study. But I mentioned curveball, 2 different directions. The other, and I'll talk you through it rather than show an example, really lives up to the full name here, prioritize hypotheses. So we saw prioritize. We didn't explicitly see hypotheses in the example I showed you. But some of them really do involve prioritizing hypotheses. And so you might see things like the client is most likely experiencing X as evidenced by Y and Z. Something like that could be pull down menus where we're actually building or prioritizing hypotheses. So a little bit of a curveball there. That's the first half of the case study, the first 3 questions, right? Recognize cues, analyze cues, and prioritize hypotheses. It can be helpful, I think, to think of the first half of the case study as the nurse as detective. And what do I mean by that? If you think of a detective, right? If you watch some of these crime dramas, or we do at home for sure. But anyways, how does the detective operate? Well, the detective has a lot of clues, some better than others, of course, right? And has to figure out which ones really matter the most right now and what they might mean. And then from there, figure out, well, what might be going on or where should I start? So, anyways, nurse as detective. Now, I like to give you friendly language for each of these skills before we jump to the second half of the case study. So for prioritize hypotheses, remember curveball, I'm going to give you 2 different things. What's going on? Or sometimes, where do I start? Okay. Second half of the case study always starts essentially the same way. Between the lines, fourth question in the case study is really looking at what kinds of stuff could help. So I'm going to read this one. The nurse is speaking with the physician regarding the treatment plan for the client who was just diagnosed with a splenic laceration and left-sided hemothorax. This is a good cue that it's important for your grads to read the directions, right? Because sometimes we'll even have things like diagnoses presented here. Anyways, easy to skip that, I bet, but it's important to read. So for each potential order, click to specify whether the order is anticipated or contraindicated for the client. We call this item type a matrix, or more specifically, matrix multiple choice. Matrix multiple choice means for each row, you choose one of the options. Sometimes what you'll see, or your grads will see, is called matrix multiple response. And in that case, we might have these different columns with checkboxes. And for a particular row, you could check more than one answer, sort of like a select all then apply. So at any rate, matrix or matrix multiple choice is what we're looking at. The skill in our measurement model is called generate solutions. That's our fourth box. It goes with our fourth item in the case study. But one of the ways we can think about it is what could help. As we go to the fifth question in the set, let's take a look at this example. The nurse has been asked to prepare the client for immediate surgery. Which of the following actions should the nurse take? Select all that apply. There's that item type again. Anyways, what's going on here? Well, here are all these different things that could help. Doesn't mean we're going to do them all, right? Well, let's pick one of the ones that's actually going to happen, right? Surgery, prepare for surgery. And now we're getting more specific, right? We're kind of drilling down or narrowing our focus and we're saying, how do you do this, right? What are the things you need to do here? How do you do this correctly? So in terms of our clinical judgment measurement model, the fifth question focuses on take action. And you can think of it as a which or a how. In other words, if we go back to this question, we can look at it as which of these things should you do? Well, that's okay. Or we could look at it as how should you prepare the client for immediate surgery? Check, 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 right? Kind of the same either way. All right. So I like to give my friendly translation. Take action's pretty friendly already. But what do I do? Or how do I do it? Okay. Sometimes people say to me, it feels like that's what the fourth question was, right? We listed a bunch of things we might do, and now aren't we kind of doing the same thing? And here I think the nursing process can be helpful because I would say generate solutions. What kinds of things could help is in the planning phase. Take action is in the implementation phase. Another way I differentiate is I would say generate solutions is kind of like brainstorming, right? It's like if we were deciding where to go to dinner tonight, we might come up with 7 or 8 things that could all work. We're not going to go to 7 or 8 restaurants tonight, right? We're going to do one of them or maybe hit a second one for dessert or something like that. In the same way, generate solutions. Here are a lot of things that the nurse might do that might be helpful. Take action. Okay, when we choose these things, we're really doing them. So, all right, hopefully I didn't make that too confusing. Let's finish it up then. Sixth question in the case study. Here, this one says, click to highlight the findings below that would indicate the client is not progressing as expected. We call it a highlighting item. And as you sort of hover over a keyword that you like or a part of a sentence and click on it, it lights up, right? And you can click on another, you can click again if you changed your mind. But the point is, the way you indicate a response here is just by clicking on a part of a phrase or sentence. So what's really going on though? Sixth question, final question in every case study, targets the skill we call evaluate outcomes. And a way I might translate that a little friendlier is simply, how'd it go? Right? Some stuff probably got better. Maybe a few things got a little worse. Maybe some things stayed about the same. How'd it go? So with that, I'm going to go ahead and summarize the case study for you. Okay. When I used to present case study, sometimes people would say, Jason, this seems pretty scary. Well, it is Halloween today. They'd say, Jason, this seems pretty scary. Are you saying the case study is just 6 random complicated things? And the answer is no. The answer is it's super predictable and super logical. You get a real world nursing scenario. It's got a lot going on, but guess what? That's real life for your new grads, right? When they become nurses, they're going to find there's a lot going on. The client situations they enter into aren't going to feel like multiple choice questions from the NCLEX, right? Maybe once or twice, but usually not, right? Usually there's a lot going on. So what else? A lot going on. We call that our real world nursing scenario. 6 questions every single time that each have a different clinical judgment focus in this exact order every single time. So that's not random. Recognize cues, analyze cues, prioritize hypotheses, generate solutions, take action, and evaluate outcomes. Now, another thing educators used to say to me is, Jason, do you know how hard our jobs are already? Having to teach all this stuff and get our students to care about all this stuff so they can be successful. And now you've just come up with these 6 extra things that we never even really heard of before, like generate solutions and evaluate outcomes. I'm joking because, you kind of, they're not too different from the nursing process. But the point is, here we are with our testing lingo and these 6 brand new skills. And oh my gosh, isn't there already enough going on? And the reason I like to translate them into things like what matters most and why, where do I start, or what's going on, what could help, what do I do, how should I do it, and how to go, is I really like to emphasize that even though we've given these 6 skills kind of official testing names that might be new on the syllabus or in the books, they are really representing the really, really important questions that you've wanted your grads to be able to ask and answer this entire time. So really the difference is these are reflecting the things that you've always known were really important for your grads. But now if they say, is this going to be on the test? You get to say yes. So what else? Multiple new item types. You saw some of those. We saw a pull down menu. We saw matrix. We saw highlighting. We saw a lot of select all that apply that sometimes just got some extra choices. Some small print, the setting. My example, the case study I showed you was set in the hospital, but a case study could be anywhere that there's a new nurse. Anywhere a first-year nurse could work, there could be a case study. Think of a school nurse. If a first-year nurse could be a school nurse, somebody could come and write a case study for us that takes place on the playground or in the school nurse's office. That's all totally fine. Eligible content, we always say anything in the test plan. So what does that mean? If peds or psych or labor and delivery are allowed to be in multiple choice items on NCLEX, which they are, they're allowed to be in a case study as well. And in fact, sometimes we can bring more than one of these together. For example, there could be a case study starring, I don't know if that's the right word, starring a pediatric client experiencing some psych issues, for example, right? So that was the case study. I sort of take it as my personal mission, right? Jason from NCSBN. I take it as my personal mission when I present on the exam to really make sure that people understand the structure of the case study and how it ties into the clinical judgment measurement model and how it's essentially just asking the things that have mattered all along, right? So if I can check those boxes off, if some of you are nodding your head, I feel like mission accomplished. So I've got bonus material. We've still got a lot more material, but this is really the biggest takeaway I would love for all of you to have is to say, okay, I get it now. I get what those 6 boxes mean and what they have to do with the clinical judgment questions and case studies on the exam. Now, is that all? When we think next generation NCLEX and new items, is that all? And it's not. So the case study is the main way that we're measuring clinical judgment on the exam. But if you saw the case study is pretty bulky, right? A lot of information and 6 questions to go with it. That gives us a lot of clinical judgment information about your grads. But sometimes we want a little bit more, right? And we don't need the fire hose, right? We just need the sprinkler. So we also have individual items that target clinical judgment. 2 brand new item types are called trend items and bow tie items. Those are brand new for next generation NCLEX. But we'll also make use of some familiar item types. For instance, I mentioned at the beginning, which client should the nurse see first? Well, that could be a multiple choice question. It probably is. And that could measure clinical judgment for us a little bit as well. So let's take a look, though, at the 2 new ones, trend items and bow tie items. Trend item, beware grads. It looks a lot like a case study, except it doesn't say case study screen 1 of 6, but it does have a left half and a right half. I admit it, right? It doesn't say case study. It's not a case study. It's 1 item only. Now, what defines a trend item? 2 things. The first is information that changes over time. So we can see that on the left-hand side. We've got information from 10 o'clock, 2 p.m., and 6 p.m. On the right-hand side, we get 1 question, not 6, 1 question that, guess what, targets one of my 6 boxes. Which one? Any, it turns out. there's a lot of freedom if you come and write trend items for us. In this case, let's see if we can figure it out. The question here is, which of the following diagnostic procedures should the nurse anticipate? In other words, what kinds of stuff could help? Well, that was box 4, generate solutions. So here's a trend item. It happens to target box 4, but in fact, a different trend item could target recognize cues or analyze cues or evaluate outcomes, for example. So any of the 6 boxes, but just one. Okay, let's look at the bow tie item. The bow tie item's got a lot going on. Again, somebody might think it's a case study at first, but it doesn't say case study. So, okay, it's just going to be a single item. What defines a bow tie? 2 things: stuff to read on the left and a drag and drop that has a very kind of fussy structure where you drag your answers into this kind of X shape that looks a little bit like a bow tie. Work with us on that. So that's it. That's what defines a bow tie item. Well, there will be one other thing. I'm going to get to that at the end, but first let me talk about the structure. Every bow tie item has this X shape to move your answers into that has 2 things and then 1 thing and then 2 things. So I call it a 2-1-2 structure. The answer choices are coming from these lists that you see below. And these lists always have 5 choices, 4 choices, and 5 choices. I call that a 5-4-5 structure every single time. So sometimes when I show an example, right? Well, not everything on the test is exactly like this. For a bow tie item, it is. It's always 2-1-2 and 5-4-5. What else is true of all bow tie items? The headings. Actions to take, potential conditions, parameters to monitor. Those are the same for every single bow tie item, right? You could imagine some variety, but we don't do that. There are always these headings. Now, I mentioned there was going to be one other thing I had to tell you, and that is the clinical judgment measurement model. Everything comes back to that. If we're measuring clinical judgment, it goes back to that framework. So how does the bow tie item address that framework? Well, it actually does 3 different times, because let's look at our first column, actions to take. 5th box at layer 3 is called take action. There you go. Condition most likely experiencing. Well, that sounds like we're going to formulate a hypothesis. So, or prioritize some hypotheses if we like. So box 3, prioritize hypotheses. And then finally, parameter to monitor. Well, that comes as part of evaluating outcomes, which is box 6. So when we look at a bow tie item, we're targeting box 5, box 3, and box 6 every single time very directly. Now, I have colleagues that I think would also want me to say, at least indirectly, in order to get this right, your grad is going to have to recognize and analyze some cues. And what else? Which other one don't we have? Potentially generate some solutions before determining what actions to take. So potentially you could think of the bow tie item as literally checking off all 6 layer 3 skills, but I'll say most directly box 5, box 3, and box 6. Take action, prioritize hypotheses, and evaluate outcomes. Okay, so that is our look at the items. If any of you were thinking to yourself, I would love to go to Chicago, or maybe some of you are already here in Chicago, so that makes it easy, but I would love to go to Chicago and actually write case studies and bow tie items and trend items, we would love to have you. You can go to ncsbn.org/volunteer, or you can zap this QR code, which is also in your copy of the slide deck. But the point is, we would love to have you. All case studies, all items on the exam are written by educators. Nobody in this office is writing items. They all come from educators. Now, some of you may also meet the requirements of our item reviewers. Well, it's the same website to go to and sign up, and we'd love to have you for that as well. Okay, what's next? Now that I've caught my breath a little. When I first went on Next Generation NCLEX World Tour, early 2018, I think was probably my first stop, I would show the case studies. I might show a bow tie item and a trend item. And of course, the question I would get is, Jason, is that the whole test now? Are we getting rid of all of the multiple choice stuff and all the NCLEX we know and love? And it's all the new case studies and clinical judgment. Is that the whole thing? And I didn't think that would be the case. However, we hadn't yet finished our research to know exactly what the test would look like. So we've, of course, by now, because the test launched, but I think it was late 2019, we determined our structure of the exam. So I always like to share a picture to illustrate how the next generation NCLEX differs from what the NCLEX looked like before April 1st. So I like to pretend that the old NCLEX was a cheese pizza. And we know it's not, right? If the old NCLEX were a cheese pizza, your grads would have liked it better and finished faster. Oh, and it would have been cheaper too. But anyways, we're just going to pretend. So is the next generation NCLEX completely different? Is it a Caesar salad? Is it spaghetti? Is it a hamburger? And the answer is it is not. It is not very different at all. It is a cheese pizza with toppings. So that's a great way to think about the next generation NCLEX if you're comparing it to, let's say, the NCLEX that you took, right? It's the same. It's got the same foundation. It's got the same crust and cheese, but it's got some clinical judgment toppings now. So let's make that real with a chart. I'm going to compare what I still lovingly refer to as the old NCLEX or classic NCLEX with the next generation NCLEX. A lot of things have stayed the same. A lot of things have changed a little. Let's take a look. Time, 5 hours before, 5 hours now. Some of you, by the way, are thinking back and saying, wait a minute, it was 6 hours when I took it. Probably so. October 2020, it became 5 hours. And it's been that, ever since. So some of this data may not reflect the NCLEX you took, but it certainly reflects the NCLEX from October 2020 onward. So delivery, we use computer adaptive testing. I can talk more about that in the Q&A if you like, but for now, I'm just going to keep going. Total number of items went up a little, if you ask me. If you talk to your students and grads, they're going to say, oh my God, the test got a lot longer. Well, okay, I'm still going to say it got a little longer. So the old NCLEX was 75 to 145 questions. The new one is 85 to 150. I'd say about the same, a little bit longer. Now, 15 of those questions don't count. Those are us collecting data to try to figure out, is this a good question, right? It looked like a good question, but sometimes when you collect some data, you figure out, oh, I guess it ended up being really confusing. Or maybe it was just way too hard or way too easy. So ballpark, somewhere between a fourth and a third of the questions we test out aren't quite perfect and ready to go. So it's good we're collecting the data and they don't count yet, right? So we're collecting data on 15 questions per test taker so that we can be sure when we make these questions count in a year or two that they definitely are super good questions. All right, back to next generation NCLEX. We're going to take away the 15 questions that don't count. We now have 70 to 135 questions that do count for each test taker. And now I'll give a very precise breakdown. So of the 70 to 135 questions that count, everybody gets 3 case studies. Everybody. Nobody's going to get 2. Nobody's going to get 5 case studies that count. Somebody reported to me at a presentation I did that a grad came back and said that they had 30 case studies or something like that. Nope, everybody gets 3, exactly 3. So that makes 18 items because as you saw in the first part of this presentation, each of these case studies is 6 items each. So what happens when we take away the 18 items from case studies from the 70 to 135 items that count? I feel like I'm doing our taxes now. Well, you have 52 to 117 items left over, kind of a yucky set of numbers, but we'll work with it. And what do those look like? Well, 10% are those kind of novel clinical judgment items that I showed you, bow tie, trend, but they could just be multiple choice. Who should the nurse see first? But the point is about 10% here focuses on clinical judgment. The other 90% is your cheese pizza. The other 90% literally is our bank of items that we brought with us from what we can call classic NCLEX, and we're still using those items. In fact, they're 90% of the items that count apart from case studies. Okay, so final thing I want to say, I'll say a little bit more about the 15 questions that don't count. We name those pre-test items or unscored items or experimental items. Point is, they don't count. However, what do you think we are trying out right now to know if these things are going to be any good in a year or two? Well, definitely we need to try out some new case studies. So what does that mean? It means among the 15 questions that don't count, your grad could get an extra case study. Now they're already getting 3 that count, but the point is they might get one that doesn't count. Okay? And that's fair. That's within the rules here. Point being, they may come back after their exam and they may complain and say, you told me there were going to be 3 case studies. I got 4. Well, this is your reminder from me that you can then say, that's right. There were 3 that counted and 1 that didn't count. Okay. So that's our test design. Final topic I'm going to cover before I talk about results and some resources is scoring. So I know I'm giving you a lot of information pretty quickly. Again, a reminder, this is all recorded. You'll have access to watch it again if you like, and you'll have the slides. I think you already have the slides from my email yesterday. So scoring is my final topic. We've been doing some pretty heavy duty having to think here. So I'm going to give you some fun as we cover scoring because we have a scoring newsletter. It's way better than me. Trust me on this. Believe me, it has actual nursing examples and really detailed, thoughtful explanations of how each of the examples is scored. So because you've got that, I get to take a little bit of a shortcut and make it a little bit more fun. So anyways, first, let me give you the headline. On next generation NCLEX, responses can now be eligible for partial credit. Back when you took your NCLEX, everything was all or nothing. You might have taken a select all that apply, and maybe there were 4 correct responses. And if you only got 3 of them, you'd get a 0. That's how the NCLEX worked until April 1st. So now that same select all that apply, the one you took and got a 0 on. I know actually this whole audience got a perfect score, but point is that very same select all that apply item that used to be all or nothing, if it's on today's test, it is now partial credit. So I'm not just talking about clinical judgment. I'm talking about the whole test. Anything that can be scored with partial credit, we're going to do it. That's not every item. You can't really do partial credit on multiple choice, but things like select all that apply, you certainly can, and that's what we do. I'm going to show you examples, so don't worry if you can't picture it just yet. Now, we have 3 different methods of assigning partial credit. I'm going to walk you through each of the 3, but again, and I can't repeat this enough, if you really want the real deal for next generation NCLEX scoring, detailed explanations and actual nursing examples, you got to see our newsletter because you're not quite going to get that from me. Here's what you'll get from me. So we'll have a little fun. We'll do a little bit of Illinois history and culture. So the most common way that we'll assign partial credit on the exam, and it includes all select all that apply items, by the way, is called plus minus scoring. So here we go. Which of these famous Americans was born in the great state of Illinois? Select all that apply. Well, I'll give you a second to think about what your answers would be, and now I'll pop them onto the screen. So, common, Chicago, right here in Chicago. Harrison Ford from Park Ridge, although he doesn't take any pride in his Park Ridge, Illinois heritage in interviews, unfortunately. Ronald Reagan, I think maybe Dixon, Illinois, or near there. Anyway, okay. And somebody will correct me in the comments, I'm sure. I'm from California. Hey, I'm doing my best. And we got Michelle Obama as well, Chicago. So those are the correct answers, but it's no fun to explain partial credit if somebody gets a perfect score. So let's pretend somebody gave us this, right? And I used to think Abraham Lincoln was born in the land of Lincoln. Easy mistake to make, right? Let's pretend somebody gave us this. How would we score it? Well, with plus minus scoring, we would give them a point for each answer marked that's correct, but we would deduct a point for each answer marked that's incorrect. And so add it all up, 3 minus 1. They would get 2 points out of a possible 4, right? You remember the fully correct answer would have had 4 green boxes. Well, in this case, this person would get 2 out of 4. Now, bear in mind, prior to April 1st, this would have been 0 points. So now it's 2 points. So plus minus scoring is the most common example of partial credit. I've got a little bit of small print and then some trivia, we'll say. So a little bit of small print. It's possible, if you do the math, to get a negative score if we use this method. For example, if somebody didn't mark any of the correct people from Illinois and they just marked Taylor Swift, that would be 0 minus 1. They'd get -1 points, right? Okay. We try not to have our exam biased against Swifties, but the point is, if that's what they did, they would get -1. But hold on, not so fast. I mentioned a little bit of small print. We will not give negative points. So if you do the math and get negative, we're going to round up to 0. Okay. So when we do plus, point for correct, minus for incorrect, at least theoretically, negative responses would be possible, but we close the door on that by just rounding up to 0. Okay, what else? Why do we take away points? This is really important to know. Everything we do on NCLEX is for a reason. Well, pretend there was no penalty, right? I mean, a penalty feels kind of mean. Why do we do it? Well, here's why. If there were no penalty, grads would figure out really fast that they could mark every answer, just select them all, and they would always get full credit, right? Think about that. If there were no penalty and you checked every box, you'd get all the right answers, and we wouldn't take away anything for your wrong answers, full credit every time. You can imagine why we, but you too, would not want the next generation of nurses to have passed their NCLEX by simply checking off all the boxes. So that's why we do it. Now, keep that in mind, because I'm going to show you a question that looks almost the same. It's a tiny bit different, and it's the second most common way that we score partial credit on the exam. This question looks like a select all that apply almost, but it's not. Which 4 of these famous Americans was born in the great state of Illinois? And guess what? The computer will not let you check 6 boxes. It will stop you after 4. You're not allowed to check them all. So, since you're not allowed to check them all, we don't have to worry about people gaming the system, right, and taking advantage of us trying to trick the NCLEX. We don't need a penalty. So, with what we call 0-1 scoring, you simply get a point for correct things and nothing at all for incorrect things. And in this case, this becomes then a 3-point response. Final example. This is, I think, for some folks, probably the most confusing scoring method that we have. So all I can say is we use it the least, but the newsletter is a great resource, again, for real nursing examples. Rationale scoring is the name we give when we care more about relationships and reasoning than we do about the individual elements of the response. Example, let's pretend we're doing some state nicknames and somebody tells us they think the nickname of Illinois is the Aloha State, right? So we could be very generous. We could say, well, actually, I guess they knew the first thing. Well, okay, but if what we really care about is the relationship, how much do they know the relationship here? Well, we don't see any evidence that they know the relationship. So using rationale scoring, we would actually give this response 0, right? We would essentially be scoring the whole sentence, the relationship, rather than the individual pieces. So again, our scoring newsletter is fantastic for actual nursing examples, so you can picture how that works on the actual exam. With that, how did this go? Well, I can tell you, right? Boy, oh boy, the 6 months or so before launch, and I know, and we all know that NCLEX pass rates have been going down for a while, right? Something I think probably all of us attribute entirely or almost entirely to pandemic and pandemic adjustments, et cetera. Well, now here we come, right, with the pass rates falling off a cliff and introducing all of this new stuff to the exam that I would say to a lot of educators and certainly to a lot of students and grads looked harder, right? So a prediction I got from a lot of people after I presented, they'd say, Jason, I really like a lot of these changes, but are you sure this is the right time So by now, what you've probably seen is that we didn't have the pass rate train wreck. So that was fortunate, I suppose. What did we have instead? Well, we've just published updated. In fact, last week, the PN audience didn't get the new numbers because they came out literally, I think, the day after or 2 days after. You get the brand new numbers. We just published our RN pass rates, not just for the April, May, June quarter, those have been out for 3 months, but the July, August, September quarter as well. So we now have 2 quarters worth of data, 2 cohorts for the exam. At NCSBN, we like to focus out of this long, long list of choices. We focus on first-time U.S. educated. So this data is focusing only on applicants for licensure in a U.S. jurisdiction, not Canada, for example, who went to school in the U.S., right? For instance, school in Illinois. And we're excluding what we call repeaters. If somebody's already failed the test, we don't count them in this pass rate. We count them in the bottom row, all candidates, for example, but first-time U.S. educated is our benchmark, and that's what we use for comparisons. So 90.69, or I'm going to round up, I'll say July, August, September quarter, 91%. The April, May, June quarter was 94%, which I believe was a record, in fact. And I'm going to give you a little bit of history and context. So this is kind of a fun graph I made. We publish all of our pass rates on our website. You can, in fact, go back even earlier than I did. I went only to 2007. You can go way farther back than that, and our pass rates are there. So I just took the pass rates on our website, and I made this graph, and I think it shows a couple of interesting things. One of the things that it shows, interestingly to me, is every quarter, we've seen this, every quarter has its own candidate profile, right? And as educators, probably better than I do, as just kind of a testing nerd, why it would be, for example, that the April, May, June test takers every year outperform the July, August, September test takers. It's kind of interesting. These are almost parallel, but the orange graph sits a little bit above the blue. I showed the group last week, PN, where there was a little bit of messiness where this relationship didn't hold, although there, for PN, I believe it was the July test takers outperforming April. So kind of a flip-flop of this. But point is, here's a little bit of historical data. One of the things that I'll observe here is if we never fell off that COVID cliff and we looked at the sort of upward trend that was already with the graph pre-COVID, and we just kept following that upward trend, right around where we are now is about where we would have expected to be. So I like that in some ways. What I don't want to say is that somehow we have undone all of COVID, because I don't think it's that simple. COVID did really happen. We really did have this drop followed by this rather steep increase. And so I think there are other factors as well. But the point is, here's where we are. Okay, final thing I want to show you, just some quick resources to know about, and then we'll go to questions. So let's see. Yeah, okay. Sample items. In this deck, you've already got a sample case study, and you've got a sample bow tie item and a sample trend item, but let's say you want more. That's fair enough. Well, you go to NCLEX.com, that's us, right? There's a lot of NCLEX websites out there, but NCLEX.com is us, right? So firsthand, straight from us. You scroll down a little, I like to say, scroll till you get to the giant eyeball, and then you'll be there with Get the Exam Preview and Sample Questions. Those are actually 2 different downloads. Take your pick. Sample Questions is just like what I showed you today. It focuses on the new stuff, but for RN, I believe you'd get 3 sample RN case studies, and I believe you'd get 2 RN bow tie items and 2 RN trend items. So it's kind of like the samples from my slide deck, but extras, okay? Well, what's Exam Preview then? Well, Exam Preview acknowledges that those clinical judgment items and case studies on the actual test are surrounded by multiple choice, select all that apply, fill in the blank calculation, classic NCLEX cheese pizza. So if you do Exam Preview, you'll get a much thicker packet because in addition to those exact same case studies, trend items, and bow tie items, you're also going to get about 110 more questions that are much more classic NCLEX. It's just all kind of shuffled together. So that's what you get there. Now, if I got you at all excited that we've got all these awesome sample items for you, I'm going to burst your bubble just a tiny bit. So we do this in the name of transparency, which is one of our NCSBN core values. We want you to be able to look and say, oh, that's what they mean by clinical judgment. That's what they mean, by how they're going to, do a case study. So transparency, and we've checked off our box by putting these samples out there, right? And also having a guy like me go around and explain stuff. But what you won't find, and this is, believe me, I get a lot of requests for it and I understand it. What you won't see are things like answer keys, right? So we don't regard it so much as a study aid as just, although you could turn it into one, I suppose, but we mainly just regard it as a way of showing you essentially what the test looks like. So it accomplishes probably a few of your goals, not all, but at any rate, we've got that, NCLEX.com. What else do we have? The newsletters, right? If we've got over 20, if you only have time for 2, I think the 2 very best are the case study. It sort of follows what I did with you today. In other words, it really works hard to connect each question of the case study to the clinical judgment measurement model. So the case study newsletter is terrific. Also, the scoring newsletter is really, really good. And I shortchanged you a little. I didn't give you nursing examples. That newsletter has terrific nursing examples and really nice explanations. So those are 2 terrific newsletters. Where do you find all this stuff? Because we've got 20 more. Well, again, it's NCLEX.com. You got to go to the About menu and then choose Next Generation NCLEX. It'll take you to a new screen. And on the new screen, it'll ask, do you want news or videos? Well, choose news to get to the case studies. Not only that, but I believe if you choose news, you'll also get to various research papers, including the literature review that I cited at the very beginning of this presentation. So Next Generation NCLEX News has a lot of good stuff for you. The newsletters especially are worth the trip. Okay. You know what? I'm going to do one other thing before I get the Q&A. I'm looking at the clock. I got time to squeeze this in. So most underutilized resource that we have on the NCSBN website, this is my opinion, of course, but I mentioned our pass rates came out last week, for example. Some of you maybe know about what we call the International Center for Regulatory Scholarships, some really cool courses that we offer that have sort of a nursing regulation theme, but also can be of interest to educators as well, or employers. Well, we are about to open registration for winter term. What if you wanted to be the first person to know about it, right? How do you get this information as soon as it's fresh, before the courses fill up? Or how do you know the NCLEX pass rate before your neighbor does? Okay, most underutilized resource we have. If you did a web search for NCSBN subscribe, it would take you to a page where you just enter your email address, and it has checkboxes for all these things you might care about: Next Generation NCLEX, APRN legislation, nurse licensure compact, all kinds of things you might care about. You just check the boxes of the things you care about. And then what happens is, as soon as we put out information, you get it emailed straight to your inbox. You're literally the first person to know. So bonus slide, right? I don't know the slide for it, but NCSBN subscribe, if you do a search on that, it's the very first result. Fill that out. We don't send you spam. We don't sell your emails to other people. We just make sure you get this information as soon as we have it. So with that, I'm going to stop sharing my screen. I'm going to take a small sip of water because I think I need it. And then I will see what questions you have. Let's see. Okay. Oh no. Heather, I am seeing right now a question from Heather. Can closed captions be turned on for accessibility, please? I think Heather must have asked right after I started the presentation. And unfortunately, while I'm presenting, I only see my slides. I don't see the chat. The good news for Heather is I believe once the presentation is posted to YouTube, YouTube automatically will introduce that feature. So that's the good news, is the second time around, it'll be there. So my apology on that. I also believe, since all of you are watching this in Microsoft Teams, that a essentially transcript of this whole presentation will be in your meeting invitation shortly after the presentation closes. So I apologize to Heather for not seeing that until it was a little bit too late. But the good news is the closed captions will be there in the YouTube, if not the Teams transcript. Okay, other questions? Feel free to type questions into the chat. I think the nature of this meeting is that everybody's microphones are turned off. So go ahead and type in the chat if you've got questions. And I'm putting my email address, since I maybe took down that slide a little before you could have written it. Let's see if we've got anything come in through here. I think so. Okay, this is where I'm supposed to be armed with some jokes and things like that for filler. Okay, let me double check, make sure nothing new is coming in. I'm happy to give you back the gift of a good 15 minutes or so, help you get ready for trick-or-treating and all that. So we'll give it one more minute, but if not, I may sign off. Oh, let's see. Hold on. Yes. Okay. A couple questions on meds. Are we still using generic medications, and does it continue to use generic names for meds? So really, I think Gina and Tracy probably both asking me the same thing. That answer is yes, absolutely. So we continue to use only generic. You won't see trade names on the exam, only generic. Okay. I see a couple of thank yous. I think since we just got those two questions, maybe I should give it a minute in case one more comes. Okay. Normal lab range is provided. Yes. So that's what I mentioned while I was showing that case study. If we provide a numerical lab value, we will give the normal or reference range that's associated with that value. Sometimes we'll do it, you know the type where it'll say, here's the range for male, here's the range for female. We might do it that way too. But yes, and that's true for the whole exam, not just the case studies. Cheryl is asking, what about math? Cheryl, I'm going to ask if you can elaborate a little bit more for me, just so I know exactly what you're getting at there. So let me skip that for now, Cheryl, and go to Linda's question. Okay. Oh, I love it. So Linda, you're asking a terrific question. What additional research will we be doing on the new grad's ability to engage in clinical judgment? That really is the magic question. So let's go back to 2012-ish, right? And our literature review and those three numbers. Half of new nurses making errors, 65% related to clinical judgment and decision-making, 20% of employers satisfied, et cetera, right? Obviously, there was a lot of data that really influenced the decisions to move to this next generation exam with this heavy clinical judgment focus. So in a perfect world, one would think that give it a couple of years, maybe, or maybe sooner, right? We would be able to do studies, right? Essentially replicate those same studies to see how those numbers have changed, right? In a perfect world, if it used to be 50% of nurses making errors, well, maybe it would be less than 50, we hope, right? If 65% were related to clinical judgment, but now you sort of have to clear this clinical judgment bar to pass the exam, we'd like to think that number would go down as well. And perhaps more than 20% of employers would be satisfied with clinical judgment skills. So I'll say a couple things. Number one, unfortunately, right, rarely with this sort of research can we have apples and apples. In other words, and by the way, I don't mean it as a cop-out, I'm not trying to be evasive, but one of the things I will say is provided that each of those studies were replicated, and maybe we saw all of those numbers change favorably, Could we credit the exam? Hard to say, because a lot has changed in nursing since the time those original studies were done, right? Our literature review in 2012 pulled in some data from as early as 2003, right? So what's changed in 20 years? What about nurse to patient ratios? What about patient acuity? So we don't really have apples to apples. So if we saw some improvements in those numbers, I think we'd be thrilled. But could we credit the exam? Not necessarily. By the same token, if those numbers stayed flat, could we blame the exam? I don't know, right? Because again, not really apples to apples. So that's part one, is I would love to see those studies replicated. That said, I'm not totally sure that we could draw straight line inferences from the numbers today and the numbers of yesteryear, we'll say. Number two, keep in mind this was a literature review, meaning we were drawing from a lot of research, some of which was ours, but some of which came from other sources, other researchers. So in our office, I don't know if we quite have the firepower to replicate all of those studies. What I think we would love even more is if other researchers out there were to do similar. I'll make a little infomercial for something we call our Center for Regulatory Excellence at NCSBN. We actually award grants for researchers that are looking to do work just like that. If anybody's interested and wants to email me, I can kind of pass you to the correct colleague. So we would love to see some what we call external validation, right? Real world evidence that somehow this exam has made a difference. We certainly made changes based on some real world data. It feels to me like this exam is testing clinical judgment in a very meaningful way, and you have to do well to pass. But yeah, we would love to see some external validity, and whether we do that research or others do, again, I think straight line inferences could be tricky, but I would certainly be very interested. Okay, let me see. Okay, a lot of questions have come in now. Okay, good. I didn't tell jokes because we're going to need all the time we've got. Let's see, from Kristen. Is there any type of drug reference guide for students? And I'm going to say on that one, no. So at least during the exam, I want to be clear there, because of course there are drug reference guides out there in the world. Nothing that we publish, right? Nothing that we endorse. But while you're taking the exam, you know, let's say that you're trying to remember, oh, what's kind of a typical dose of blood thinner. We'll say, I don't remember the generic name, so we'll just call it Xarelto or Eliquis or something. What's a typical dose for that? Well, we're not going to have a little pop-up on the exam or anything like that. So there are certain things that either you just don't need to know on the test, or if you do need to know, you kind of have to walk in with the knowledge. Okay, let's see. Okay, so Cheryl is clarifying a little bit on the math, things like dosage calculations, drip rate. Yeah, so Cheryl, that is still a part of the exam. The short version is this. Anything that was on the old NCLEX, the classic NCLEX, the cheese pizza, is still there, right? The clinical judgment and some of the new item types have been added, but we haven't taken other things away. Now, you can imagine we got a little less because we had to make room for the new stuff, but we haven't gotten rid of any of these things. So you would still expect to see what we could call the math questions on the test. Okay, let me take one more sip real quick. Okay, all right, I'm back with you. From Taylor, is there a maximum number of potential responses for select all that apply? Yes, the maximum is 10. So if you're lettering your answers, it would be A through J. Maximum is 10. Now, when there are 5 or 6, and it's not clinical judgment, we call that select all that apply. If it's in a clinical judgment context, then when it's 6 to 10, we call it multiple response. I think the outside world just calls all of it select all that apply, and that's fine too. But anyways, okay. Any suggestions for all immunizations? There are many on the schedule. Good question, Stacy. I'm going to say in general, specific questions about content, the test plan is our authoritative resource. I know, by the way, that it won't fully answer your question, but my point is that's not something where we give any cues on the exam or where I could say very specifically, here are the 11 things that everybody needs to know walking in. So I probably don't have super helpful guidance on that. Will the students have to do some math calculations regarding drugs? Yes, Ramana, definitely. Now, keep in mind there is an on-screen calculator provided. So, if they need to do something like 23.4 times, 0.123 or something like that, they don't need to be doing that on scratch paper. They can punch it in to the on-screen calculator provided at the testing center. Okay. Some more math. It's good. I probably didn't say it. My own background is math. So when you give me the math questions, I just feel most comfortable. Are conversions given? For example, 8 ounces equals 240 mils. What I'll say there is yes, especially when they're needed. So something many of you know is that the NCLEX-RN exam is not just used for US licensure, it's also used for Canadian licensure. And of course, up in Canada, the metric system reigns supreme. So, example, let's just pretend, maybe this doesn't happen in too many NCLEX questions, but let's just pretend it says, the client is 6 feet, and then it'll say in parens, 2 meters tall, right? In other words, the conversion is just built right in, usually in parentheses, right? If you remember maybe the vital signs tab that I showed in our case study, it gave a temperature in Fahrenheit. And then in parens, for our Canadian friends, we gave the Celsius. So yes, we provide the conversions directly within the item or within the case study tab. Okay, what else? Sometimes my computer is slower than my phone, believe it or not, for this. So I'm going to check on my phone and see if something new came in. I think I am keeping up though. Okay. All right. Well, a nice thank you from Tracy. Well, Tracy, thank you. It's a long presentation with a lot of information and it's kind of dense. And I've learned over time most educators would rather have a lot of information, kind of packed in so you get it all rather than, kind of 30 minutes, but you only get a third of it. So I sure appreciate everybody sticking with it and being patient. And, I realize it's a lot to digest, right? Okay, I think what I will do though is at this time, unless something brand new pops up right now, I'm going to say, everybody, thank you very much. Thank you also for the really hard work you do as nurses and educators. In my mind, those are the 2 most important professions in America, and y'all are doing both. So that is just tremendously valuable work that you do. I know there was probably a time where Next Generation NCLEX did feel like, oh no, one more thing. But I hope between this presentation and maybe some of the resources and learning that you've done over the last couple of years, you no longer see it quite that way. Again, I'll go back to what I said earlier. It's the stuff you always cared about, but now when they ask, is it going to be on the test? You finally get to say yes. So with that, thank you very much. Thank you to the Illinois Nursing Workforce Center. And again, a reminder, in the next 2 weeks, you will find this all on the YouTube channel. Keep my email. I'm here for you anytime. Thanks, everybody. Enjoy Halloween.